Well, thank you for inviting me again. I would like to share with you some ideas about the combined use of FFR and OCT in clinical practice. My name is Elvin Kedhi. I'm an interventional cardiologist in Belgium and a professor in Poland. So the FFR Concept Evolution started with a deferred trial where non-ischemic lesions do well, that prove that non-ischemic lesions do well on optimal medical treatment. But although here, PCI patients had similar outcomes to the FFR-guided defer group. And the real concept of FFR started to get ground when, after the FAME trial, which showed that the PCI treatment of only ischemic lesions is better than PCI of all angiographic lesions. So basically, only when we went to study this to do FFR assessment in multi-vessel, we saw a benefit, and that's where the FFR concept got ground. And then there was a transition of the concept of the FFR from a tool that defers to a tool that mandates revascularization with the FAME2 trial, which showed that the revascularization of the FFR positive lesions was better than optimal medical treatment alone. But then again, we have to say that this was driven by the need of revascularization in about 20% of the patients. So basically, the FFR concept is a smarter way of revascularization that definitely reduces the need for PCI while reducing angina. However, as you could see here in the FAME2 trial, the MACE was lower in the patients who had PCI, but this was driven mainly by the revascularizations, as you could see on the upper part of the screen, while death and myocardial infarction did not change. And this was not the only study that showed it, but a larger study that was based on treating the ischemic lesions also failed to reduce MACE for a primary outcome of cardiac death, myocardial hospitalization, myocardial infarction, and hospitalization for unstable angina, as well resuscitated cardiac arrest. But also here, we saw again that there is about 20% of the patients that will come and require revascularization in the group that had a optimal medical treatment arm. So how to interpret this 20% crossover? And these patients that really need revascularization. And these are two types of patients: the ones who were severe already at the baseline with very severe ischemic lesions. And there was also patients who might have had intermediate lesions, but that had plaque progression and that were positive at FFR, that become FFR positive during the follow-up, but were negative at baseline. So if we look to the FAME2 5 years result, we see though that on a longer follow-up, there is a benefit in myocardial infarction, although also the patients that have PCI, they also have spontaneous myocardial infarctions. And there is, as you could see here, a reduction of about 30 to 35%. And the same thing, if we look on a long follow-up also for ischemia trial, also here we have exactly the same type of reduction. So it was 65, the hazard ratio is 65 in the FAME2 and it's 0.67 here in the ischemia trial. So exactly the same amount of patients have it, but also the patients in the invasive group have myocardial infarction. So where do they come from? Are these coming from vulnerable lesions? And we look here that this is still something that happens also, as I said, in the invasive group, where we addressed all the ischemic lesions. So this remains an unaddressed issue for the moment. Now, if we look to what we know from the anatomopathologic studies, there is the progression is that we have a plaque that becomes vulnerable, it ruptures, it creates a thrombus, and this will either give an occult or overt acute coronary syndrome. If the blockage of the thrombus is not complete, the plaque will heal, and the healing of it will create a stenosis. And that's where the patient will have stable or crescendo angina eventually. And this is exactly when we will perform the FFR. And we know that if we perform an FFR, about 1/3 of the patients is positive and will go for revascularization, while 2/3 of them are negative and will be treated medically. So we know that medical treatment gives plaque stabilization. However, some of these lesions, they remain vulnerable plaques, and the prevalence of those is about 20 to 40%. Now, what is the relevance of it? And as I said, if we look to the pure maths, we say that 1/3 of the patients is positive and 2/3 is negative. So it means that 2/3 of these potential vulnerable plaques, that could be in either positive or negative FFR lesions, so about 70% remains untreated. And that's exactly what we see also here. It's exactly this difference that we saw of about 30 to 35%. This is the unaddressed part of that could originate from vulnerable plaques. Now, how does this translate in the data that we have till now? We have a very nice study from a collaboration from Korea and Japan when they look to FFR positive and negative lesions and plaque vulnerability. And as you could see here, as I said, 1/3 of the FFRs will be positive and 2/3 of them will be negative. This is also what they found. And as you could see, there is a large number of vulnerable plaques or plaques with high risk, because this is a CT study, also in the FFR negative lesions. And of course, as the lesion becomes more ischemic, the higher the chance that the plaque will be vulnerable. However, in absolute numbers, how you could see here, also the FFR negative lesions will have vulnerable plaques that then remain unaddressed. So how do they behave? Of course, as I said, this is the prevalence of them, the incidence of these high plaques. But if we look to the totality of these plaques in the FFR negative, they are higher than in the FFR positive lesions. And indeed, as you could see here, the majority of the events during the follow-up comes from these high-risk plaques of FFR negative. So they have an event rate close to 50%, while the FFR negative plaques that have no high-risk features, they have a very benign outcome. And as you could see, this difference starts already to be noticed at 2 years and continues between 3, 4, and 5 years. Again, here, I'll show you that the majority of the events during the follow-up occurs from plaques that were FFR negative rather than from plaques that were treated. They were FFR positive and were treated. And these were plaques with high vulnerability features. Can we identify vulnerable plaque in the cath lab? Yes, we can. And actually, at the moment, the OCT is the only one who could really look to the thin cap fibroaderomas. And we had the chance to do in Europe the combined trial where I was a PI of. And we showed that actually these high vulnerable lesions, the TICFAs, they had a much higher rate of MACE than the rest of the FFR negative. So if you have a thin cap fibroaderoma and you have a FFR negative, you're still at high risk of having a future adverse event. And the primary endpoint was cardiac death, target vessel MI, clinically driven target revascularization, or hospitalization. So you could see here, it's a 5-fold event rate if you have a TICFA versus not. Is the combined the only study saying this? And I say no, because you could see clearly also the study from Takashi Kubo. He see that the lipidic plaques seen on OCT, especially the lipidic plaques in TICFA, they were the only ones that gave events during the follow-up in these patients. And he clearly showed that, of course, the lipidic plaques in general, they are higher, have a higher event rate than the patient, the event rate of having a new acute coronary syndrome than patients without a lipidic plaque, but particularly the thin cap fibroaderomas almost double the event rate. And if you have a lipid-rich plaque and a thin cap aderoma, then the event rate is clearly much higher in these patients, and is exactly what we also found in the combined trial. Now, coming back to where we started, what is the impact of these persisting inflammation vulnerable plaques? What is the relevance of it? What we also learned from the combined trial is that when the plaque ruptures, it's not that it heals and it becomes stable. You have a progression, longitudinal progression of these plaques, and within the same lesion, you can have a progression of atherosclerosis. So you could have TICFA on an old rupture plaque, a healed plaque, all within the same lesion. So there are some plaques where the inflammation persists. They could have a higher rate of events. And this what will, again, as shown from the combined and also the study from Dr. Kubo, this will give, again, a new acute coronary syndromes, either acute or overt, and that's where physiology alone is not enough and imaging should be considered. So the take-home message is that the FFR-guided revascularization significantly improves symptoms of angina, however, not sufficient for significant reduction in acute coronary syndromes, MIs, or mortality. And we know now that the lipid-rich plaques and TICFA lesions are at the high risk for future events independently from ischemia. And now the question is, we identify these lesions, so what to do with them? Should we treat these lesions? We do not. Should we put them on stronger medical treatment? We do not have this evidence yet, and that's where we should be looking in the future. Thank you.
Thank you, Elvin. You raised, we've heard you present the combined data earlier, and we understand that combining the two is always an advantage to have more than physiology, also having an imaging support. But practically, just seeing how much is imaging used all over the world and how much is physiology using all over the world, and to try and see whether we have answers for the large number of people who are out there getting MIs, it is not something which is truly practicable. It is not. So we still probably have to find better biomarkers or better non-invasive modalities by which we can supplement this information. Very truly, you've identified very well that the same unmet need exists in the FAME data as well as in the ischemia data set. And really, adding imaging would help us. And we also should understand that FFR is a continuous variable. We should not get around by just having a yardstick of 0.75 and 0.80 in our interpretation. So thank you very much for a very nice presentation.